Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Till Luca.
Welcome to the Thinking Practitioner.
Till Luca here. Books of Discovery has been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. In these trying times, this beloved publisher is dedicated to helping educators with online-friendly digital resources that make instruction easier and more effective in the classroom or virtually.
And I'm Whitney Lowe, and Books of Discovery likes to say learning adventures start here. They see that same spirit here on the Thinking Practitioner Podcast, and they're proud to support our work, knowing we share the mission to bring the massage and bodywork community enlivening content that advances our profession. So check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy and physiology at booksofdiscovery.com, where Thinking Practitioner listeners can also save 15% by entering Thinking at checkout. Thanks again so much to Andrew Beal and to the Books of Discovery team for their support of our podcast. All right, Mr. Till, good to see you again and be back with you again this week.
Likewise, Mr. Whitney.
Yep, you've been out in the desert for a while. It sounds like you were touring around a little bit there, taking
took
some fresh
an
air
hour
in.
trip. That's right.
Yeah.
Headed out to Canyonlands, and we're doing some backpacking and some camping out under the stars. Really great. How about yourself? How you been doing?
Doing good. Trying to get a bunch of work done for me. This is sort of the calm before the storm hits with baby bird season, with us doing a lot of rehab here that keeps my wife very busy and me sort of helping out in the springtime and early summer. So this is the time period we try to get a bunch of stuff done and get prepared for that. So
you're getting ready for that important thing you do to help spring happen. You're helping the birds be part of that whole scene.
That's right. Yes, indeed. So, and so consequently, we start thinking about things when we're out in these spaces. And today we're going to think about some things shoulder related, I think, right? Isn't that what we're talking about here today?
Yes, shoulder related, shoulder pain, subacromial pain, rotator cuff pain. There's a lot of crossover there, also known as shoulder impingement syndrome. But like I said, that crossover thing, I'm excited about it because it's so common, but it's also pretty broad. But we'll get into that, I think, as we go, about how that broadness is part of the story. But yeah, we're talking about shoulder pain.
Excellent. And I think we got a whole lot of stuff we're going to dive into here today, which means lots more resources to look into. And I think we will have a handout on this episode as well to explore some of this stuff in greater detail, right?
That's right. You can go to either of our websites and request the free handout. Just click the link there in the show notes. And then I also want to give a plug for Diane Matkowski's Shoulder Jam event coming up in May. If you're listening to this live, check that out. We'll put links to her event on our site as well. So you and I are both doing that with her, Whitney. So this is a fun preview conversation.
Yeah, it's going to be a fun event. I'm looking forward to hearing and exploring and seeing a lot of other perspectives about various aspects of shoulder things from folks from all around the world participating in that and getting some really good input on those things. So it's going to be fun.
Yes.
Yeah.
And part of the reason I think she picked that topic and part of the reason we're talking about this is because it is so common. There's so much interest in shoulder pain amongst manual therapy practitioners, massage therapists, body workers. We have, in my own training school, we have a whole lot of topics we teach. The shoulder topics are always some of the most popular. If you just go down the list and see which ones are getting the clicks, which search results are landing activity, if the word shoulder's in there, it gets attention. So, which tells me that a lot of body workers are wondering, how do you deal with shoulder issues?
Right.
Do you see that too?
So, yes, indeed. So tell me, Till, for those trivia nerds, how common is shoulder pain?
Shoulder pain. Well, how common is shoulder pain? It's super common, but subacromial pain in particular, which we're going to try to focus on today, subacromial pain is the most common type. And they say that's something between 44 and 65% of all shoulder pain complaints. So shoulder pain is super common. This particular type of shoulder pain is really common too. The subacromial, say probably the most common type of shoulder pain. And then I also just want to, as we're giving the context here, just say that it's a big deal when your shoulder hurts. It's, it disrupts your sleep. It's hard to get comfortable, which has all sorts of effects that cascade into maybe the pain perpetuating, but then also being in a bad mood or, and just not feeling great.
Yeah.
And then, it impacts your function. You're able to do things. You can actually have, measurable weakness, of course, but then also you just avoid doing stuff when your shoulder hurts. So this is a high impact area.
Yeah. Shoulder being, the joint of our body with the greatest range of motion and involved in so many different things.
Uh,
I noticed this was interesting. I've noticed for myself because I've got a little minor subacromial pain thing going on in my shoulder,
yeah.
which over the last several months, I was doing a whole lot of work emptying my father's house. I was moving a lot of furniture, moving a lot of heavy stuff. And I think that's probably a lot of what led to it. But I know a lot about shoulder stuff. I've dealt with it for years. And then
Mm.
still, even with all of that, I notice this, like I reach overhead, like there's that pain, like, uh-oh, I'm
Mhm.
going to be in trouble because I feel that, subacromial pain thing. And then that starts all this whole cascade of things running around about what's possibly going on there. What's probably wrong? What do I need to do about it? All that sort of thing. So,
Okay, so you're referring to a bunch of interesting stuff there. The
yeah.
activity you did of cleaning out your dad's house, and then the sensitivity in a particular motion, raising your arm, you said up overhead, and then you said that cascade of associations or fears or assumptions that triggers in a way.
Yeah.
So I think all those things are part of the puzzle. Whatever it is that we do that aggravates it, the actual movements that seem to trigger it, and then the way that we react to that. It seems to
Yeah.
be
And
part of the
these,
story.
exactly. And so I think those are the kinds of things, a number of those factors that we want to pay attention to as we're talking with our clients and taking histories of what's going on, just to remember things are oftentimes not just one simple little thing, but there's often a number of different factors that are going to be a part of that. So,
Yep.
yeah.
Well, let's narrow it down a little bit. Let's start with subacromial impingement syndrome, or SIS. It's that there's a lot of debate around that term, and we'll get into that. But first, let's start there and define that. That was okay if I jump in on that, Whitney?
Yeah, absolutely. Yeah. So why don't we even start with the words
Okay.
subacromial, and
Oh
sort of
yeah.
like zero in on where we are and what does that mean? And so, yeah, let's jump in. Tell me what you got there.
Well, subacromial, let's talk about where that is in a second, but it's basically pain on the front or side of your shoulder when you lift your arm, either out to the side or out in front, shoulder abduction or flexion, or sometimes a little rotation, but basically pain on the front or side of your shoulder. And this impingement syndrome was a term that was first used by Neer in 72, and that became kind of the dominant explanation for why a lot of people's shoulders hurt with that particular motion. The idea being that there was some sort of impingement or compression of the structures in that subacromial space. That's the space between the coracoacromial arch and the humeral head. And that compression would lead to tissue damage or degeneration, and that would cause the pain.
Yeah. Let me also jump in real here just for a moment to kind of do a little brief anatomy refresher and talk about what are some of those tissues that might be impinged.
Okay.
Because a lot of times there's an emphasis, just in terms of broad generalizations. People say, oh, I got bursitis in my shoulder or something like that, because there is a bursa there, and that bursa is richly innervated, and that can often be painful.
Yep.
But we have a number of different tissues that might be susceptible to the potential compression and impingement in that area, such as, the subacromial bursa. We have the supraspinatus tendon in there. We have the upper margin of the glenohumeral joint capsule. We have the tendon from the long head of the biceps brachii that's subjected to compression in that region. And we'll talk a little bit more in a few moments too about some other structures, even things that you might not think about as much, like the upper, more superior margins of the subscapularis tendon can get
Mhm.
compressed, especially during some of the forward flexion motions in there. So, and
Mhm.
keeping in mind too that the joint capsule, the glenohumeral joint capsule, is richly innervated. So, irritation of that capsule itself potentially getting impinged there.
So this you've named a bunch of structures, but let's zoom out a little bit. I'm skipping. I had a little bit on your outline, but you get this sense that this is in the shoulder. Most of you know where these structures are, but let's just get really specific. Where is that acromion, Whitney?
So if you just like put your, fingers on the lateral part of your shoulder, that, stiff, flat sort of table that you feel on the lateral edge of your shoulder complex is the flat surface of the acromion process. So we're talking about the things that are right underneath that. You can feel that sort of sharp shoulder edge there, and that is your acromion process. And then just if you roll over toward the front side a little bit anterior,
Uh-huh.
you may be able to feel also another kind of bony
Bony.
projection, kind of like a little pinky finger size sticking forward, and that's the coracoid process.
Okay, so
And
now you're
then,
not talking about my arm bone. You're not talking about my humerus. You're medial to that.
right, so we're
So
on the
the
front side of the shoulder here at
front
this
side of the
point.
shoulder, not the
Yeah,
lateral
yeah,
side. But yep, that coracoid process sticking through from the scapula.
exactly. And so the coracoid process and the acromion process are both structures of the same bone, which is kind of interesting. There's projections of the scapula, and
Mm-hmm.
there's a ligament that spans between those two projections, and
Mm-hmm.
that is the coracoacromial ligament. And I've always found this sort of anatomically interesting because we generally think of ligaments as structures that are maintaining stability
Mm-hmm.
between adjacent
Joints,
bones. And
right,
here you have
across the joint.
a ligament spanning between two structures that are part of the same bone that never move away from each other. So why do you need a ligament there?
Why do you need a ligament that
Okay.
doesn't cross a bony joint?
Yeah.
Tell us.
So, well, I don't have the actual answer
I'm
because I have
sorry.
not been able to ask the builder, but I have a theory. Okay.
Yes, okay. What's your theory?
So predominantly the purpose of that coracoacromial ligament is to offset the potential damage to the coracoid ligament because the coracoid process, because there are
Oh,
three strong muscles
yeah,
attached to the underside of the coracoid process, all pulling it in a downward direction.
yeah,
There's the short head of the biceps brachii, the coracobrachialis, and pectoralis minor.
love
They're
it.
all pulling that coracoid process down,
That's
and
true.
generating sufficient force could potentially break it off.
Or at
Um,
least, yeah, I could totally get that. I mean, that little thing is
yeah,
like skinnier than your little finger. It's a
right.
big bony projection, and there's a lot
Yeah,
of force on it. So yeah,
right.
we probably need some kind of supporting
So
structures there.
go up above it, tether it, hold onto it, rope it with the coracoacromial ligament, and hold it in position there. So
I like it.
that's my theory.
No,
Yeah,
but your point is, so now that we know what we're talking about, I'll just go back to what you were saying. Any of those structures in there could be say, the irritated structures. You said impinged structures, but we're going to get into the debate around that, whether there is actual impingement or not. But any of those structures, and you've also used the term nociceptive driver, the anatomical thing that seems to be the origin of the nociceptive signal. So any of those structures around there, including the acromioclavicular joint, because sometimes a
yeah,
fall on the shoulder, something like that, will irritate, I mean, injure that joint, and the irritation that comes can be very similar to this pain. Classically, the impingement syndrome is thought to be non-traumatic in most cases. It just kind of comes up from on its own, or maybe from use, or maybe from cleaning out your dad's house, but it's not thought to be a traumatic injury. But there's so much crossover between all these different shoulder symptoms that we're taking the big picture view here.
yeah. So yeah, we'll dive into some of the other mechanics and problems here. So after we sort of go through some of these terms,
Yeah.
you've mentioned this discussion of impingement. I want to bring up another sort of distinction too, as they were looking, the terminology that's been used over years since Neer first kind of explained this. There's
Right.
oftentimes a distinction made between primary and secondary impingement.
Yeah.
Primary impingement being a potential compression of those structures that's based on the architecture of the shoulder. So, meaning that maybe you have a small subacromial space, or you have, for example, something that we see frequently in people over time developing um, sort of osteophyte buildup on the underside of the acromion, causing the acromion to change its shape. And you
Yes.
see references to what's called a hooked acromion, where
Yes.
the acromion sort of you decrease space underneath it between that and the humeral head. And so that would be a primary impingement because it's a structural problem. The secondary impingement being some type of potential compressive damage in there that's due to usually faulty biomechanics or something in the way you're using their shoulder, which may not necessarily be directly related to the structure of the area, but more about like the fact that you're doing something over and over again that's causing those tissues to get irritated in there.
So irritation
So,
secondary to an activity, or impingement secondary to activity, as opposed to being primarily due to the structure involved.
right.
That's a
Yeah.
classic distinction there.
Yeah. So, and another interesting thing that I was coming across when I was doing some reading on this recently is in some of the discussions about this is distinctions between what they were calling intrinsic factors and extrinsic factors of rotator cuff damage, mainly talking about supraspinatus, because the supraspinatus is one of the most commonly involved tissues in this area because it can really, its tendon is very vulnerable underneath the acromion process.
Yeah.
Extrinsic factors being those like external compression and pressure against bony structures nearby, like the acromion process or osteophytes on the underside of it. And intrinsic factors being some of the things that might occur with overall tendon degeneration within itself that lead to weakness in the tendon and possibly the development of tears within the supraspinatus tendon that may not necessarily be caused by something scraping on it or pinching it from outside the tendon, but more of just the sort of, just like overall tendonitis in other places, just as some degree of tendon degeneration occurring in there.
Well, we could branch off into all sorts of discussion about degeneration points of view, inflammation points of view, and then how sensitivity can arise from that, or it might even be independent of that.
Yeah.
Yes, what you're doing is you're giving us a great outline of the way that the shoulder impingement has been classified, both in terms of types, which is based on the degree of mechanical damage, and on the internal, external, and then also on the location of the impingement, which is the intrinsic, extrinsic kind of thing.
Yeah. So those are important classifications. And I also wanted to bring up one more kind of division or classification of these types of problems. Most of the discussions that you'll see in the literature around shoulder impingement syndrome, rotator cuff pathology, and that sort of thing focuses on what's called subacromial impingement, which is an impingement underneath the acromion process. But as we talked about a moment ago, we have that coracoid process also, and then the ligament that spans between those two. And the coracoid process, the ligament, and the acromion process all together make up a combined, well, let's call it a structure that we refer to as the coracoacromial arch. So all three of those things together make up the arch. And sometimes the impingement is farther toward the coracoid process and felt more on the front side of the shoulder as opposed to the lateral side. And in that instance, it's referred to frequently as subcoracoid impingement instead of subacromial impingement. And this tends to affect more of the subscapularis tendon and the biceps long head tendon underneath the coracoid process and in the subcoracoid region.
Okay, so we've gotten pretty granular there. We've gotten a lot of variations. We've gotten some specific locations. Is it time to talk about the debate yet?
Yeah, let's talk about the debate. What is that debate?
Okay, the debate is there are a couple. One is around the mechanism involved, and the other is around the way we describe it, the way we talk about it. And the debates have been pretty large and pretty vocal, and they seem to be maybe settling out. They've been going on for about a decade. There's about 4 decades ago that NIR came up with this classification system. In the last decade, the people have been saying, well, wait a minute, maybe there's not always impingement. Impingement syndrome assumes that there's some mechanical impingement. Maybe there's pain or symptoms that are independent of any impingement. And for evidence of that, there's almost everybody narrows that space in normal motions, and the measurements that are given us, but that space narrows all the way down to 2 millimeters in people without any symptoms at all, and opens up as much as 17 millimeters. And that's just part of normal function. So there's a compressing of that subacromial space and all those structures that run through there just in normal motion without any symptoms at all. And then the correlation between shapes and symptoms hasn't borne out in the research. And it turns out there isn't a correlation between acromial architecture and particular symptoms. You can't reverse engineer it and say, if you have this architecture, you're more likely to have a symptom, it turns out. Now, that's not to say that it's not always involved. There can be a compression involved, but most people, I think, at least from my reading and my listening, Rachel Chester being her, both her research she's done, but also in the podcast with Physio Edge, we'll put I'm saying that wrong. What is it? You know which one I'm talking about?
It is
Whitney?
a Physio Edge, I believe, was the one.
I think Physio Matters. I think I gave their competitor a plug. Physio Matters,
Okay.
I believe. We'll put the right link in the show
Okay.
notes.
They're both good, so listen to
They're
them
both
both.
good. There you go.
Okay.
But she's saying it's formally called the subacromial impingement syndrome. But since this suggests that what's needed is more space, we now know that acromial shape is not associated with pain. She's preferring, I think most people, the term subacromial. Help me out here.
Pain syndrome.
Thank you. So subacromial pain syndrome rather than impingement syndrome.
Yeah.
So that's describing the symptom rather than the presumed mechanism.
Yeah.
Since we're not sure of the mechanism, she's saying let's describe the symptom.
Yeah.
What do you think?
And I think that's an important distinction because, describing it as an impingement syndrome immediately brings our focus into how do we make more space in there so that it doesn't get pinched. And, we'll tap into this a little bit when we talk about the treatment, but one of the things that's led to this re-examination of this whole idea of subacromial impingement syndrome is some of the treatment processes that have been used to address this, such as surgical decompression and making more space in there, and acromioplasty and things like that have done specific things to make more space, have found
Right.
some of those surgeries work really well. But in a number of those instances, they get just as good of effects with various other types of procedures. And in fact, they've done a number of sham surgeries where they didn't actually do the subacromial decompression, but they just did an arthroscopic incision, and people got better. Their pain decreased, even though nothing was actually done in there. So it really changed the perspective, I think, a lot on how much is structure really the cause of this. And so
that's the debate. That's huge. Yeah. And that's huge for me because my training is a Rolfer and structural integrator. And then the training that I gave to people said, let's create space there. If there's shoulder pain, whether it's even adhesive capsulitis or even something like a rotator cuff irritation, any of those things, we can quote in quotes now, create space. And that seems to relieve symptoms. And that was presuming that compression was the problem. Well, when I read and hear this stuff, I go, well, of course, we don't know that compression is the problem. We know that sensitivity and pain are the problems. And there's probably ways we can work with those very directly. That might involve decompression, but maybe not. Maybe it doesn't have to.
Yeah, because another thing that was kind of interesting that I ran across this and looking at, again, some of the systematic reviews of these different treatment procedures is that even in a number of the individuals who had failed rotator cuff repairs. So, for example, they had rotator cuff surgery and the surgery was performed, and then for some reason or other, it failed. And they went back and looked at the rotator cuff with an MRI. They saw like severe, significant tears still there, but the person was out of pain. Well, why does that happen?
That's right. And the other side of that was just looking at the incidence of rotator cuff tears. It's so common. I think the number pops in my head of 1/3 of people have some sort of tear or damage visible over a certain age, visible on a scan, and they don't have symptoms. So the correlation there between rotator cuff image findings and symptoms is pretty poor as well.
Yeah. So, that leads us to then thinking about, all right, then, well, what is it? Because obviously something's going on there. And so, some of the theories now that have emerged that are suggesting that what we're probably looking at is a complex of factors in many people that might be, mechanical factors, because clearly I think there is a role for the mechanical idea of impingement being a driver of pain sensations in there. That certainly makes sense.
Sorry, I'm going to interrupt because do you say is the qualifier on some people okay to add in there?
Yeah.
Okay, because that's how I think about it too. Yeah, I think there's often people
for certain people that's a factor. In other people, it may not be the major factor. So what is it in a number of those other people? And there have been sort of alternating theories proposed. One of them is related to that. What we're probably seeing in many of these complaints is, and we can see why it's easy to blame the mechanical factors of potential impingement and compression here, because there's not many places in the body where we see this same kind of scenario where soft tissues get pinched between two bony structures. So this is a place where you get pain and you see the potential for that pinching between two bony structures, and then you jump to the conclusion, all right, the pinching of the soft tissues is the cause of pain. But we have tendon disorders and tendon pain all over the body in places where we don't see that. So what was that?
I'm thinking Achilles tendon. There's not a lot of structures there that pinch it, but we get the same kind of tendinopathies and tendon irritation.
Exactly. There. Patellar tendon, like extensor tendons at the wrist and the forearm, all those kinds of places. So why not? Is this potentially an issue here that you have the same kind of metabolic or possibly age, in many instances, age-related degenerative processes in the tendon that might cause those kinds of pain sensations? Because we see a lot of subacromial pain in older populations. So,
sixth decade of life, they say.
Yeah.
Which makes our 50s. Sorry, Whitney. I'm getting past that.
You are. I'm rapidly crashing out of my 50s as well this year. So, So I'm making the best of the last 6 months of my 50s I got left here. So,
good. Enjoy it.
Yeah. Where were we? Oh, so talking about metabolic factors and things that might be related to tendon degeneration, may be related to some of the pain sensations for a lot of these people.
Now wait a minute. That's again like we're questioning the assumption that impingement causes pain. Isn't there some reason to question the fact that degeneration is part of the pain in tendons as well? Do you know what I'm saying?
Well, why would we, if we're saying it's possible that all these things could be present in different degrees for different individuals? I'm not sure. I'm kind of getting what your question is there.
My question is, you said tendon degeneration, age-related tendon degeneration, et cetera. There can be age-related tendon sensitivity without degeneration.
Yeah, sure.
So there can be painful, irritated, and inflamed even tissues without degeneration. This goes back to the tendinosis debate. In a sense, which again, that pendulum has swung back and forth. We used to think it was all inflammatory, then we thought none of it was, and now we're realizing that there's probably both involved, and it's less clear sometimes what the primary generator is, but both of those are routes to help make it better.
Yeah,
either
I think so.
With the metabolic questions you mentioned, like the inflammation ones, or the perhaps degeneration or healing, kind of questions there as well, or mechanical loading.
Yeah. I love going back to, and maybe with something that we can make a link to on our visual handout or something like that, but Greg Lehman's concept of the painful cup. He talks frequently about each individual comes to us with a cup that might be comprising a unique group of factors that may be pain irritants or aggravators. And some of those may be metabolic factors. Some of those may be mechanical factors. Some of them may be overuse. Some of them may be, all kinds of things, stress related, whatever. Each individual brings a unique cup of those things to us. And it's important for us to kind of consider what are all those factors that might potentially be involved as we try to evaluate the nature of that problem in order to construct a treatment strategy that we think is going to be effective.
I know the visual you're talking about. And it's also used for stress. Greg uses it. I forget who he attributes it to, but it's also the idea that anything in that cup can raise the water level of it, and when it spills out, we have pain, or we have an episode, or we have a flare-up, or we have something like that. And you're saying that maybe degeneration could be in that cup, maybe metabolic inflammation could be in that cup, etc.
Yeah.
Maybe activities could be in that cup. Lack of sleep could be in that cup, etc.
Yeah, exactly. All those things I think potentially involved there. So, looking down here, you've got a couple other things that I want to look at as we talk about subacromial pain syndrome. There's some other things, we've talked about tendon disorders in particular, but you've got some other things you've mentioned here that we need to consider as possible causes, and some other,
what are you looking at?
I think
getting us back on track. Like what?
Yeah. So you mentioned like subacromial bursitis and calcific tendonitis and, rotator cuff pathologies and things like that. These are all some things that might be part of this whole bigger picture of subacromial pain syndrome.
Well, yeah, that's part of the debate around calling it impingement, that there could be lots of things going on there that could cause
Yeah.
that sensitivity or pain. So that's why somebody like Derek's is saying, 2014, he's saying it's all non-traumatic, usually unilateral shoulder problems that cause pain or involve pain, that they're localized around the acromion, and they often get worse during or after lifting your arm or sometimes rotating the arm. That's his kind of SAPS, subacromial pain syndrome
Yeah.
definition. And those things you mentioned, the bursitis, the tendinitis, tendinopathies, rotator cuff could all be part of it, as we said. And now like we said, I've been saying all along, we don't really have a big agreement on what is causing the pain. But as you said too, there's a lot of agreement that there's a lot of factors in that cup.
Yeah.
So, uh, how would we know what might be causing that pain? Is it time to talk about tests, you think?
Yeah, this is a good time to segue into, I think, looking at, how do we figure out the nature of these problems? And,
Yeah.
the one thing in terms of reading a lot of the literature around this that seems evident still is that there are no real absolute definitive ways to identify this. So the best that we can often do is look at the accumulation of evidence through testing a number of different strategies and trying to keep a bigger picture view about what may be potentially going on here. So one of the things that I always emphasize greatly and would start with is just the critical importance of a thorough and comprehensive history, because this is something that I just think a lot of soft tissue practitioners don't do thoroughly, is dig into a lot more of the questions about the nature of what causes pain, how did it come about, the previous involvement of those areas, and really probing for a good picture of the things that potentially produce pain prior to doing our physical examination. So those are critical things that I think are necessary at the real outset, and then we maybe get into some other things that might be identifiable during the physical examination part.
So you're saying taking a good history, having a good thorough conversation with your client beforehand is crucial to your way of thinking. How do you use that information? Do you then start to form a hypothesis for yourself about the factors involved?
Yeah, so let me give an example of how that would drive what goes on in the physical examination. So let's say, a person is talking about certain types of things that they can't do. Like when I try to reach up and lift this garage, to pull the garage door down, like lift my
Yeah.
hand in this position. So you've got a physical activity motion that they've described is one of the most painful things they can think of, that reminds them, this is what hurts every day when I do this. So I'm making note of those motions and the direction and position that shoulder is in that they say hurts a lot. So
Uh-huh.
I'm probably going to leave that motion till the end of my evaluation process, because if I start having them try to repeat that when I start to test range of motion and test their movements in their shoulder, if I test those most painful motions first, I may flare up the whole thing and make everything else hurt. And then it's going to be harder for me to tease apart what structures might potentially be doing that. So the history questions drive a lot of what we decide to go evaluate more specifically in the physical examination, maybe also the order in which we attempt to do those things too.
So you're sorting the cards in your hand. The hand you've been dealt, you start sorting them out and going, okay, these are the ones I'm going to play last because they might be the irritating ones. I want to save them and don't want to flare things up early in this process.
Yeah.
Okay,
Yeah.
great. And are you also, I mean, I do that too. I'll just make a statement there rather than ask. I want to hear your thoughts about it. I do that too. And I'm also asking questions like, what makes it worse? What makes it better?
Mm-hmm.
As clues to me of some of the possible mechanisms or at least factors involved.
Yeah.
But I'll ask things like, uh, have you had, say, manual therapy, body work with it? Did it help? Because some of these things that it might involve inflammatory reaction can be worsened by a too aggressive approach. And I want to know if that's happened before so that I can, modulate my ambition
Yeah.
toward helping it out.
Yeah.
And then it might also be, if it's an ongoing issue for someone, and I suspect I might ask something like, how is your sleep?
Mm-hmm.
Yeah.
Yeah.
How are your stress levels? How do
Yeah.
you address that? What resources do you have for dealing with stress? For
Yeah.
example, what is
Yeah.
your level of physical activity? Because that's been really clearly correlated with symptoms right here in this joint, someone's overall physical activity level.
Yeah. So again, all of these factors of history are really crucial. And just to make another point about that too, a lot of times what I'm doing with the history is also
Oh,
setting up the process for how I'm going to make comparisons when I look at patterns. And for me, this is just part of the way I think, is that I look for patterns that tend to make sense. So, for example, I might ask in the history if a person says like, "Oh man, it really hurts when I lift my hand up
yep,
overhead to grab the handle on the bus when I'm on the subway or whatever,"
right.
and then I'll ask them, "Well, does it hurt when you are lying down in bed and you just have your hand draped up in that same position? Does that hurt?" And then they'll say either yes or no to that. So now I'm making a comparison between active movement and passive positioning of the shoulder in that same position and seeing if there's pain with both of those things, because one of them may indicate more of a problem with the contractile tissue like the supraspinatus that's engaged to lift the arm up and grab the subway handle. The other is just a positional thing. And then I'll go
I
through
wanted
those
to
same
stick out my
motions.
highlighter. Sorry, I'm taking out my mental
Yeah,
highlighter, interrupting you and saying, let's
yeah,
highlight that,
yeah,
because you're saying you're trying to find out if contractile tissue is involved by
yeah,
bringing in an active motion of
yeah,
that
yeah.
structure.
Right. And then we compare that with a passive motion of that structure by not engaging the contractile tissues. And then when
Mhm.
I do my, actual physical examination, I'm going to test those motions and do a manual resistive test, which will engage the contractile tissues, but not put the shoulder in that position where it might further be getting compressed. And again, that helps me tease out a pattern of, is this particularly like a supraspinatus involvement, or might it be a non-contractile tissue like the bursa, the ligament, or something like that? And that sort of helps tease apart what structures I think are most involved in that process. So for me, this ability to look at these patterns of active motion, passive motion, and the resisted motions, and then compare the results from them is really helpful in trying to discriminate where I see those tissues involved. And to give an example of that, we'll include something on the handout. I've got these little charts that I put together that help you think about what happens to those
Yes.
different tissues during those different motions when you're doing the evaluation process.
You
So
gave me a preview of those. Those are a great cheat sheet. You get to like compare the motions with these different variations you
yeah,
described and
yeah,
get a little key under what structures might be involved.
yeah. So
Okay, so let's say, can I ask you another question about that?
yeah,
Let's say you do your comparison of active and passive, and let's say you suspect contractile tissues, which I assume you mean myofascial structures or muscle fascial units, myofascial
yeah,
units called
yeah.
muscles. All
Muscle
right,
tendon units. Yep.
muscle tendon units. Let's say you identify one of those. Then you just what? Then you go rub the heck out of it, right? Now that you know what it is.
Maybe. I used to say that, yeah, I'm going to go rub the heck out of it because I'm going to, break up the scar tissue and do all the other things that we were told that we were doing to those things from the impingement process. And so now I'm not so sure that those are actually the things that are happening, but,
Yeah.
lots of different strategies may be helpful in there. But this also does help, I think, a lot because this can help a lot in patient education in terms of what we're trying to tell our clients, the things to kind of avoid early on, the things to maybe focus on, gradually work your way back into doing this kind of thing, but don't start, doing this kind of thing early on because you're going to overload that really irritated,
Oh, okay.
muscle tendon structure.
So you're using the results of those tests to educate the patient and help them understand which things they want to grade or experiment with or go slowly back into.
Yes, because I mean, for me, the assessment drives the treatment. So, the assessment's giving us a good um, roadmap for where we think the primary problems are, whatever the nociceptive drivers are for that particular problem, and then how do we chart a course that's going to be able to get them back on track and decrease any in further aggravation of those involved tissues and find some results there.
Well, I was obviously joking about rub the heck out of it, but would you say that you choose some techniques that might specifically touch or work with those structures you've identified? How do you approach
Yeah,
that?
absolutely, because again, when we've talked about this before, while our ideas might change about the narrative behind what we're doing, we found treatment strategies over the years that seem to be really effective. So something like deep transverse friction of irritated structures has, for years been shown clinically to be pretty effective in dealing with a lot of chronic overuse tendon problems. And I'm using that as your sort of rub the heck out of it model.
Okay, the most aggressive kind of
Yeah.
approach, perhaps,
Yeah.
to really get in there and work it. It's
Yeah.
irritated, let's go after
Yeah.
it. Let's just really go for it.
So our narrative around that formerly was that we were, helping to break up fibrous adhesions and realign scar tissue that was, getting that to be working well. I'm not so convinced any longer that that's really what's happening for a number of biological and physiological reasons that make that less plausible to me. But I know it gets good results in many instances. And I still think there's a lot of advantage to what we might be doing with descending modulation and a targeted treatment approach that gets sort of the whole neural and metabolic processes going in there. I think there's still maybe some potential benefits of the things that we've seen about increasing fibroblast activity by pressure and movement on some of those structures that might have a role in the healing process and the remanagement process. So I think there's a lot of potential benefits to those things that just might be a little bit different than what we thought they were previously.
Mm-hmm. Yep. And you're just making me think. I know we've got into this in other episodes as well about working with inflammation and tendinopathies and things like that. But from my side, I rarely rub the heck out of it, although I will sometimes think about working fairly directly in a way that I'm consciously stimulating an inflammatory response. Now, that is playing with fire because that can flare things up. So I do that really judiciously and with clients who we have both the rapport, but especially who have the kind of resilience metabolically, medically, age-wise, and things like that.
Yeah.
To deal with a flare-up if we inadvertently cause one.
Yeah. And the other thing that I would note here too, and this is, with a number of the techniques that are listed on the handout for, valuable ways to address this, a lot of what we may be doing is really kind of focusing more on normalizing scapulohumeral mechanics and just making the shoulder function better, of just like more balanced or more, freely moving. And that seems to have really helpful effects as well.
Now, I've changed my thinking on that.
Hmm.
There's a bunch of handouts in there with techniques from me. I don't know if you're talking about those or from the techniques. Sorry, the things you're going to put in the handouts. I'm actually not thinking of what am I thinking? I've gone away from, say, the scapular dyskinesis idea of like helping the shoulder blade and shoulder move normally, in quotes. And I'm more generally thinking of adaptability.
Yeah.
So I'm not trying to restore proper biomechanics as much. And some of this, again, is Greg Lehman. Some of it's just the time and years of working. I'm less trying to restore proper biomechanics and more thinking about how can I help that shoulder adapt to whatever demands are being put on it. And the other part of that is desensitize. How can I work with pain per se, pain itself, using my touch and maybe through those mechanisms like you mentioned, like the descending modulation. Sometimes it's a really gentle touch that helps desensitize. Sometimes it's pressure that feels really right and helps desensitize.
Yeah. And that is essentially what I was getting at, that I think a lot of those techniques seem to be aimed more at just restoring optimum function, whatever that may necessarily be. And that doesn't necessarily mean you've got X range of motion available in your shoulder, but you're trying to get functional movement restored there.
I'm jumping all over you because I want to take the word optimal out of there.
Okay.
I want to say it's restoring function. It's restoring adaptability, and much less oriented around an optimal or around an ideal or around a normal, even quote normal than I used to be, and that I was trained to be, and that I train people in. Now it's more like, can you adapt?
Yeah.
Is there a range of options? And do you have enough of proprioceptive acuity, enough sense body awareness, or enough responsiveness to be able to respond to the demands, or coordination even, to respond to the demands that life puts on you?
Yeah. And I think that's a really important distinction because, for the person who wants to be an Olympic shot putter, that range of motion and generating power through a very great range of motion is really important. And for that individual that just needs to be able to get the can of beans off of the upper shelf, and that's really all that's, the major demands there.
It's
The
my highest
the
ambition
optimum
in life
function,
with my shoulder, right?
adaptability is going to be a bit different there. So for sure.
Yes.
Yeah.
Yes. And so, but I mean, that's also to say that there are so many factors involved in a happy shoulder.
Yeah.
It is spine, rib cage, scapular relationships. It is the way I sit.
Yeah.
It's the habits I have around where my shoulders rest.
Yeah.
But I'm no longer thinking about, let me reposition the shoulders back to an optimal place. I'm more thinking about, can they have a full range of options, both protraction and retraction?
Yeah.
Can I elevate as well as depress? And then can my glenohumeral joint be comfortable in moving in all sorts of directions? So I'll do the same things in that test you're describing, but I'll look for a sensitivity, and then I'll work with the sensitivity in whatever way seems right. Either it's calming it down, or it's challenging it gently, or it's helping someone have other options for them
Yeah.
until that can be more comfortable.
Right. Excellent. Yeah. I want to backtrack for just a moment. I know we've kind of ventured into talking about some treatment strategy things here.
Yeah,
There's one more important point that I want to make
please.
about the sort of assessment evaluation process, because for years there's a lot of emphasis placed on a number of special orthopedic tests,
Uh-huh.
the empty can test, the Hawkins Kennedy test, the NEAR test, as the means for identifying these particular subacromial pain complaints. And
Yeah.
just want to emphasize that, a lot of the research literature that's been looking at the evaluation process has not found many of those procedures to be highly specific and highly accurate in really nailing down what's happening in these areas. So like many other places, I think there is a decreased emphasis on the critical importance of those testing procedures. And that's why I go back to this whole process of looking for patterns and looking for more comprehensive pictures that paint an understanding of what's happening here in conjunction with the history to evaluate what's going on. Because too many people have jumped to simplistic kinds of evaluation recipes just by running through a couple of these orthopedic tests. And to me, that's a real big mistake that has
Yes.
shown to be less accurate.
Or the opposite can be true, where it gets way more complicated than
Yeah.
maybe we need to make it too, that we need to, do 5 tests and we have to do them precisely. And then the illusion comes up that we know what is involved, and then we can just do our technique and it'll be done.
Yeah.
It's not only does it not have to be so complicated, but often even if we do the test correctly and we get a result, it's not always what helps us strategically in terms of helping someone resolve the situation.
Yeah.
So I've moved more and more toward the actual treatment being the test, where if I can reproduce the symptom, if I can find it, I can identify it, and then I can help someone adjust their relationship to it or adjust the way you're both moving in the moment, but also the demands they're making on their body. I've done some really good work with them at that point.
Yeah. Yeah. And I want to also bring up a point here too about
Please.
the biopsychosocial factors. You mentioned this in relation to some of our treatment strategies, but there's also something, and I don't hear this talked about a lot, but I do think it's relevant. And that has to do with the biopsychosocial aspects of assessment, that
Oh,
when you go through, for example, this kind of evaluation, this sort of detailed evaluation process with somebody,
yeah.
and you really take the time to explore this. I mean, I have had so many clients say to me over the years, "Why has nobody ever done this with me before?"
Mm,
And to me, you have built a high degree of rapport with your client that's also established a degree of interest that you're expressing in them, and a degree of confidence in you as a practitioner that I think really spills over into how effective that treatment becomes. Because we talked about this in our episode about expectations
with Mark Bishop, that's
with
right.
Mark
Yeah.
Bishop. This is an example of where those kinds of ideas of expectations really play out into the treatment success, because you have really already established a strong degree of rapport and trust and confidence from your patient, because you've gone through this detailed, thorough, comprehensive evaluation process with them, and they think you know what you're doing. So
There you go.
I do think
There you
that
go.
there's some real strong benefits there.
And that also, there's a nonverbal component of that, or aspect, let's
Mhm.
say a nonverbal version of that, where once you get someone on your table and you start working with them, if they sense or feel that your hands are listening to them, if your hands are discovering things about their body and showing them things about the body they weren't aware of, and in fact, there's listening to what's going on in their body, that same kind of trust can deepen and be multiplied in a nonverbal sense as well. So
Yeah.
there's like the thorough history taking in the interview, and then there's the thorough listening that we do with our hands that also leverages that expectation effect and lots more.
Yeah, absolutely. So, any other key components you want to bring up related to treatment-oriented stuff? I know we've gone through a lot of
We've gone through a
stuff here,
lot.
and yeah,
Yeah, I mean, yeah, I think probably as we're starting to wrap up, the bigger question that we've gotten into a little bit is what helps, but let's go through it a little systematically. What can we do that really helps when we have that kind of sciatic shoulder pain we're talking about? One of the first things I do is I make a call for myself based on what I'm hearing from the client. What is it that I want to address in my work? They come in and I don't want to just jump and assume, oh, it's pain that we're going to try to, quote, fix today. I want to listen and say, now, how are they experiencing that disturbance? Is it pain, or is it the stiffness, or is it weakness? Or are they giving me clues that it's about the apprehension, the guarding, the fear, the uncertainty, the worry about things getting worse again? What essentially is the domain that I want my work to affect? Because so often, and I see this with us hands-on practitioners, we get where it is and we think we know what to do. We understand
yeah,
where the location is, and then, yeah, I got a technique for that. Let me go do it.
yeah,
But the disturbance, the thing that might actually be upsetting to the client, might not have an anatomical location. It might be, again, more of a apprehension or a fear. And there's ways that I can slow down and listen, and like with both my words and with my hands, like we've mentioned, that actually help shift that apprehension as well.
yeah,
And then stiffness, the distinction between stiffness and pain. Your tests that you're going to put in the handout there have some nice ways of dialing down, is it contractile or non-contractile tissue? But stiffness and pain are different. So really in my treatment, when I really get time to work with someone, understanding that something can be sensitive without being stiff, and it can be stiff without being sensitive. And just because we make it less stiff doesn't mean it's going to necessarily feel better. That's one of the fundamental assumptions, from decades ago in our work that is being called into question too.
yeah. And in an instance like that too, the stiffness may not be the same thing as what is the pain driver. The stiffness may
That's
be
right.
the reaction to
There you
the
go.
perception of pain or the fear of pain in that area, and so the muscles are guarding and limiting motion, and then that's what's perceived as the stiffness. So,
Absolutely. Yeah.
yeah.
And so that's part of why so many people get such dramatic results from one session too, that we can really quickly turn down someone's guarding,
Mhm.
and then their body realizes, oh, I can do things I didn't think I could do. And all of a sudden there's a whole lot of range and motion that comes back.
Yeah.
So
Yeah.
I do focus a lot on gentle mobilization.
Yeah.
And in particular, that inferior glide of the humerus, if there's that subacromial pain, that pain in those places we've been describing. And my old explanation was I was decompressing that space. I was
Mhm.
preventing so much compression. And I still think that's probably going helpful in some cases. But for sure, that the work I do to help make sure there's the inferior glide capability of the humerus, and I'll put the handout in that explains that, uh, it seems to be really effective for this
Yeah.
type of work.
Right. So some really good strategies there, and we've uncovered some nice dilemmas to consider and think about with subacromial pain here. Looking at some of these causes and causative factors. Any last thoughts that you want to wrap up with there?
Well, there are details more than summary thoughts. There's still a
Yeah,
couple little details I want to catch there.
yeah,
That we've talked about being really tissue specific or structure specific, but often we'll find that anything in that region can help, and it can be surprising what does. Anatomically, I'll often think of anything that crosses the glenohumeral joint or anything that crosses the acromioclavicular joint as being a possibility. But then there's also times, especially when something's really painful, that starting somewhere completely different gets even better results in the shoulders than starting locally.
hmm
And then the same has been found to be true with, say, strengthening protocols, where sometimes exercises that target the most painful structure are too hard for people to do, or too painful, too challenging, and irritate things, and that overall physical activity has been shown to be really helpful for a painful shoulder, painful subacromial shoulder pain. Just the people that exercised, say, 10 minutes a day had far fewer severity of symptoms than the people that had no physical activity.
Yeah.
So just a little bit of overall health can help quite a bit.
Yeah.
With so many things.
And that really highlights, too, the factor that so much of musculoskeletal care is very mechanically driven. It's very sort of mechanically focused in, like, we've got this problem in the shoulder, so now fix those things in the shoulder, and that's what we need to do. And in many instances, that does limit our ability to see some of the bigger, broader picture of overall movement enhancement through the individual that might be able to accomplish a big chunk of that work without irritating the local structure.
So maybe we're setting people up to go out in their life and live in a way that helps the issue. Mm-hmm. And there's less emphasis on taking care of it all right there on the table and getting it all resolved right there.
Mm-hmm. Yeah, absolutely.
Anything else from your side around what helps?
No, I think we've really we've drilled down into some fascinating and great stuff there. And of course, we can explore a number of these things in greater detail, which we probably will do in some future episodes, and come back and revisit some of these things.
I'm already making some notes. So, that's right.
Yeah. So
I know you have some very specific shoulder courses in your repertory.
Yeah, we've got a good comprehensive shoulder course in our online orthopedic massage program, where we delve into a lot of these things in great detail, and you do as well, right? Over there.
Right. Both the 1 hour short versions, but then a larger principles version.
Yeah. And
then there's also Diane Matkowski's shoulder jam coming up. That we'll put links to all that stuff in our show notes.
Yeah.
Should I jump into our closing messages there, you think?
Yeah. Do we have a closing sponsor message here today?
Closing sponsor today is Handspring Publishing. And when I was looking for a publisher for a book that I wanted to write, I was lucky enough to ended up with two offers, one from a huge international media conglomerate. I'm not kidding you. And the other from Handspring, a small publisher in Scotland run by 4 great people. And I'm glad I chose them, Handspring, because not only did they help me make the books I wanted to share, the Advanced Myofascial Technique series. And by the way, it's volume 1 that has 4 chapters on the shoulder and covers a lot of the techniques I'm going to put in the handout. But their catalog has emerged as one of the leading collections of professional level books written especially for bodyworkers, movement teachers, and all professionals who use movement or touch to help their patients achieve wellness.
Yes, and Handspring's Move to Learn webinars are free 45-minute broadcasts featuring their authors, including a recent one with Robert Schleip and Jan Wilke, talking about the new edition of Fascia in Sport and Movement, where they share new research on hot topics such as kettlebell training, foam rolling, fascia's role in sensation, and more. So head on over to their website at handspringpublishing.com to check those out, and be sure to use the code TTP at checkout for a discount. And we thank you, Handspring, and thanks to all our sponsors. So if you can, stop by our sites for the handout we mentioned, for show notes, transcripts, and extras. You can pick up links to that also from my website at academyofclinicalmassage.com, and Till, also on your site there, where is that?
advanced-trainings.com. We love to hear from you. Email us your questions or things you want to hear us talk about at info@thethinkingpractitioner.com, or look for us on social media. Just my name, @Tilluca. How about you, Whitney? Where do people find you?
People can find me also on social media under my name, Whitney Lowe, there as well. And we do encourage you also to follow us on Spotify, Stitcher, your favorite podcast platform of choice, whatever that is. Rate us on Apple Podcasts or wherever else you happen to listen. And if you're unable to find it in any of those locations, you can always grab a copy of Pink Floyd's Dark Side of the Moon and play it backwards on a 78 RPM turntable and hear us there.
Is that true? I didn't know that.
It is true. It is true. I tried it. Yes.
How'd you do that?
Yeah.
Thank you, Whitney.
Thank you, sir. Enjoyed it. And we'll see you again in 2 weeks.
Okay.